Welcome to this video on systematizing the evaluation and management of syncope in the emergency department. We will walk through a four-step framework based on the 2018 and 2026 European Society of Cardiology guidelines. While syncope is common and often benign, the emergency clinician's primary mission is to identify life-threatening conditions. We must remain vigilant for hidden killers like arrhythmias, myocardial infarction, pulmonary embolism, severe aortic stenosis, sepsis, and gastrointestinal bleeding. To effectively diagnose, we must define the deficit. Every instance of syncope involves a transient loss of consciousness, or TLOC, but not every TLOC is syncope. True syncope is characterized by rapid onset, short duration, spontaneous complete recovery, and global cerebral hypoperfusion. This video introduces a four-step clinical filter for managing syncope: performing a primary assessment, conducting a targeted diagnostic evaluation, risk stratification, and finally, making a safe disposition decision. Step 1 is the primary assessment using the ABCDE approach. Always rule out immediate life threats like airway obstruction, respiratory failure, hypotension, or cardiac arrest. Manage these emergencies with specific protocols before proceeding to the syncope evaluation. Step 2 focuses on the diagnostic yield funnel. Every patient requires a history and a 12-lead ECG. Avoid indiscriminate testing like routine head CTs. Focus your resources based on your clinical assessment. The patient history should follow the temporal sequence: what happened before, during, and after the episode. Always consider contextual modifiers, including past medical history, current medications, and family history of sudden cardiac death. A targeted physical exam is essential. Evaluate the head for signs of injury. Palpate the carotid for irregularities. Listen for cardiac murmurs that might suggest aortic stenosis, and check extremities for persistent neurological deficits. When assessing for orthostatic hypotension, ensure the patient lies flat for 5 minutes before taking a baseline blood pressure. Recheck after 3 minutes of standing. A positive result is a drop in systolic pressure of at least 20 millimeters of mercury or a reading below 90. The ECG is your cardiac red flag monitor. While a normal ECG suggests lower risk, you must actively look for high-risk patterns, such as AV blocks, ventricular tachycardia, long QT, or Brugada patterns. For precision diagnostics, start with blood glucose to rule out hypoglycemia and hemoglobin to assess for anemia. Order other tests like troponins, D-dimer, or imaging only when the clinical picture indicates a specific trigger. Use the TLO stoplight matrix to categorize the patient. Conditions like arrhythmias and myocardial infarction are high threat. Neurological and metabolic causes are complex mimics, while reflex and orthostatic causes are generally benign. Step 3 involves risk stratification. Low-risk patients typically have a clear, benign etiology and normal exam. High-risk patients may have suspected cardiac syncope, abnormal ECG findings, or a history that indicates a more serious underlying condition. For high-risk patients, the observation window is critical. Continuous ECG monitoring is mandatory during the initial hours to capture transient arrhythmias. If no concerning findings appear, you can reconsider the disposition. Finally, be mindful of clinical caveats. The elderly may present with falls rather than clear syncope, and trauma should always be evaluated alongside the syncopal event. Always distinguish between true syncope and transient coma. Step 4 focuses on the final disposition decision. You must balance the patient's presentation against risk factors. Patients with stable vitals, a normal ECG, and no structural heart disease may be candidates for discharge with reliable follow-up, while others require admission and monitoring. This master algorithm summarizes the process. For every patient with transient loss of consciousness, perform an ABCDE assessment. If the cause is identified, treat it. If not, perform risk stratification to determine if the patient should be discharged or admitted for further investigation and monitoring. In summary, maintain structure over instinct using ABCDE, ensure a 12-lead ECG for every patient, stratify risk to guide admissions, and perform only targeted testing. Prioritizing these steps will help you provide safe and effective care for your syncope patients. Stay updated with caring docs.